If you gave credit plus coded the X-ray, you're saying that you get credit for both the X-ray interpretation under 70,000 code as well as the EM review under the EM section. And so you're giving that credit for that interpretation twice. You only want to give it in one area. So if you're actually coding the medicine, the radiology, the clinical lab code, code it under that. If you're not being able to code that because somebody else is reading it in a different group, a different employer, however it works in your practice, then you would be getting that point for doing that separate read only. Now, another area that I hear a lot of people asking about is how do you get credit for an interpreter? I know a lot of physicians out there are frustrated. They spend extra time associated with an EM service that involves either an interpreter for a foreign language or might require a translator, and the Social Security Act does require those services to be provided. So how do you actually get credit for the extra time that that's taking? And the key is you want to get your physician to write poor historian and then record who the historian is and why the patient was not giving the history. This could apply to cases involving a babysitter, even for our poor dads. You know, what was I supposed to know that too, they ask. My wife said just bring her in. Yeah, she's got an ear infection. I don't know how long it's going on. You know, they don't know the history. It takes a lot of work to ask questions, get more information out of them about the small child that they've brought in. Or you've got the case where the teenager is speaking and translating for her mother about her little sister, and so it takes a very wieldy circle in order to actually get the answers. You want to be thinking of coding based on time in these kinds of issues. So if time then ends up, and that's counseling and or coordination of care, if that ends up dominating these encounters, then you would be using the time-based coding in order to report those scenarios. If they're not getting credit under the time-based coding, and so you're actually going to be looking at things like the review of data, then you want to give a point in this table for decision to obtain history from someone other than the parent. Now on to the difficult part. Let's determine the ENT scenario's level of risk. So we're going to go back to our scenario. You select the risk level based on the single highest element identified in the table of risks 3 columns. You don't need one element in each column. You instead assign the patient's risk using one element in the one column that represents the highest level. To get started, classify the level of these elements: presenting problem, the diagnostic procedure ordered, and the management options selected. So in our ENT example, we've got some tricky areas. We've got our basic ones where the physician orders no tests, reviews, no records. So we've got our no data there. But now, do we classify the problem of a decision for tubes and otitis media as a presenting problem that's stable, chronic or low, an acute uncomplicated illness, or an acute illness with systemic symptoms? That would be moderate. Now, this is a tricky angle because you'll get different opinions on it. And you're going to have to look for more details in order to figure out something like otitis media and with a surgery where it's going to be. The history that the staff and ENT document will be important. If there's documented hearing loss, balance dysfunction, speech-language delay, tympanic membrane rupture, you could argue that it represents an acute or chronic illness that may pose a risk to loss of function, classifying the presenting problem as high. Although documentation might sometimes support a high presenting problem, you'll probably be above low for otitis media leading to surgery. In most cases, the risk would be at least moderate, falling under either chronic illness with progression or acute illness with systemic symptoms. And so there, you could really be looking at the actual otitis media diagnosis that they're using. Are they using an acute code or are they using a chronic code in order to be able to help you look at that presenting problems level? Next, we're going to count our tests in our labs to classify column 2. So we would be focusing on the workup that the ENT ordered. Because our physician in our case didn't order anything, we have no circles in column 2 just for our diagnostic procedures ordered. When you scan down the options in category 3, over here our management options selected, you may hesitate regarding whether to count the tube placement as a minor or major surgery. So are you going to count it under here, this minor surgery, or elective major surgery. So you've got 3 different areas here. Now for our tubes, realistically a tube placement is minor surgery. At least that's what most of us tell our patients. The table of risk classifies a minor surgery as low risk, assuming the patient is generally healthy without comorbidities. A risk factor such as asthma increases the table of risk value. The best bet before selecting the management option levels, check if the patient has had any identified risk factors. This refers to the patient's unique medical history that might affect the outcome. For instance, if the patient in our case has asthma, you would circle minor surgery with identified risk factors instead of the minor surgery with no identified risk factors. And that would increase this category's level from our low to our moderate. So really what this identified risk factor is all about is, does the patient have any specific conditions that make them an increased risk candidate? Not just across the board, any surgery and whether it involves risk or not. That's a given. That's already been included in that table. The identified risk factor with or without throws a lot of coders. The same detail arises for scopes. The table lists diagnostic endoscopies with no identified risk factors as moderate risk. So down here we've got our diagnostic endoscopies with no identified risk factors. And then on our next one, we've got our diagnostic endoscopies with identified risk factors. So, and once again, the same thing that we were talking about with no or with identified risks applies here. You don't increase the risk factor just because the patient's undergoing a scope. Instead, you give a physician moderate risk for ordering a scope. All patients undergoing a scope face a certain amount of risk, so that ordering of the endoscopy is always the same. The exception is if a patient has an underlying health condition, such as a recent heart attack, that makes his service more questionable. Then you would increase the risk factor from the moderate to high. Because the risk for that patient is increased, you should give the physician credit for high risk to represent ordering a scope endoscopy for a patient who has identified risk factors. Another area that I see people struggle with on this table of risk is in the prescription drug management. You might not be giving your physician enough credit if you limit prescription drug management to prescription writing. These management option answers will help you avoid this auditing pitfall and others. How does CPT weigh managing drugs? The table of risk lists prescription drug management as a common clinical example of moderate risk. So over here in our management options, we've got prescription drug management. It's pretty high level. And think of how many times your physician writes a script, how many encounters, what percent is that? It's pretty high. And now you're talking about moderate for all of those.